Thank you for that, and I'm proud to be the only person on the panel representing the Navy. These are my disclosures, which I will pretend that we had up for 7 seconds. And this is my actual disclosure. So I was asked to talk about this, and I've had 6 deployments, and I've done 0 laparoscopic trauma cases, even though I'm an MIS trained surgeon. But the reason for that is not because it wasn't appropriate, it was because I didn't have the tools. And so when I deployed to Tarankout in Afghanistan in 2011, I went back and to prepare for this talk, I wanted to see, I looked through all of our case logs. So we saw a little over 300 patients. And going through that, I found about 26 of those patients could have used a laparoscopic or an endoscopic tower because we didn't have the capability of either. We could have prevented at least 3 medevacs because we felt like doing a open cholecystectomy on an active duty person would not get them that return to duty, as Dr. Wilson was talking about. And so we medevaced that patient to a place that had laparoscopic capability. Additionally, if you know anything about active duty military people, whenever it's pork chop night, they are going to get food impactions, and so having your endoscope and bringing your Roth nets is really good, just putting that out there for you guys. Additionally, we did see patients, particularly patients who were local nationals who were injured in the fight, and these patients weren't often medevaced to higher levels of care, and we were told to keep them at the World 2, and so we had bullet wounds or stab wounds in the flank and buttock, and we had no way of really investigating that other than a fast exam or a plain x-ray. We didn't have any C-arms. We certainly didn't have CT scans. And so even a negative fastness patient doesn't mean that they don't have a hollow viscous injury. And then even more, you would see these patients with this scattered fragment pattern. And so most of these are probably superficial, but these are malnourished patients often, very thin abdominal walls. Easily one of these could have penetrated the peritoneum. Again, if it's a hollow viscous injury, may not have a positive fast. And you may have scatter from the metal in the fragments and not get a good image when you're trying to do imaging of the patient. So as she mentioned, I was in EMF in Djibouti, and we did have one medevac from a ship that did not have laparoscopic capability, and they sent us a patient for a hernia repair so that they could, again, have that return to duty immediately. If you know anything about ships, most people sleep on bunk beds, and for our enlisted, they're like 3 high, and so if you can imagine having a fresh open inguinal hernia repair and trying to climb up to that top bunk, that can be sometimes problematic. So I want to go back to this paper that Dr. Wilson talked about the abdominal trauma surgery from 2002 to 2016. So this is from the Joint Theater Trauma Registry, which we all, when we deployed there, had to report our outcomes to. And I think this is really important, right? Because we need to know what the pattern of injuries were so that we can teach our future generations of military surgeons what they should expect and what they need to be prepared to do. And as he said, there was not a lot of laparoscopic cases. And so the conclusion of this paper was that, well, we need to de-emphasize laparoscopic training for GME and not why did we not have so many laparoscopic cases? As Dr. O'Donnell showed, there's probably only 4 to 5 of the multiple Role 2 and Role 3s that had the capability of laparoscopy in theater. So this is a kind of a false number. And as he said, one of the most common operations at the Role 2 is this laparotomy, not otherwise specified. So Dr. Ritter, if he's here, obviously being our program director and an MIS-trained surgeon, was like, stop. We need to keep teaching people MIS. And he said, obviously, open abdominal trauma skills are the most important thing, but we need to also know how to do MIS. We need to have a basic laparoscopic skill set. And particularly in this theater, it's mature. We haven't moved to these locations. We have air superiority. Having laparoscopic capability is very important. And interestingly, the trauma surgeons doubled down, and they responded to him, and they said, there's logistical issues, there's sterilization issues, there's resupply. Just like he said, how are you going to hump a CO2 cylinder that weighs 83 kilograms? There's just, it's not useful. And they said the technology's not currently available. And I think that that's fair if you're looking at it from a high-income country perspective, and this is what your vision of a laparoscopic tower is. But this is why diversity in medicine is important, right? Because we know from our global surgery colleagues that we have low resource highly portable, cheap technology that we can use for laparoscopy. And so this paper came from Dr. Lucas, who's another Navy surgeon, and he showed that you can actually use these surgeries and have a laptop. And how many of us deploy without a laptop? Very portable, very easy. We want to look up our CPGs. We want to be able to Skype with our family. Everybody's going to have a laptop. And then you have wireless technology. This company's here. There's a poster actually available for looking at this, not only in the arthroscopy, but in the laparoscopy set. So when you think about that re-sterilization and being able to have this low footprint, very easy. If you worry about your light source, how am I going to have this LED, this box that I'm going to carry around? It's hot. We got bulbs. We're going to have to resupply it. You can have a wireless LED source. It's actually pretty easy and pretty cheap. And then the CO2 canister. You don't need to use gas insufflation to do laparoscopy. Just last year in surgical endoscopy, they published this about gasless laparoscopy, which is being used around the world where they don't have access to these things. And so you have basically an abdominal wall retractor, but instead of opening laterally, you're opening up. And so you can easily use with your same open abdominal set a retractor that will help you do gasless laparoscopy in a forward deployed setting. And when we talk about sterility and resupply, when I was talking to some other surgeons about this, they're like, well, you have to have specific special equipment to re-sterilize your cameras. Well, that's an America thing. The rest of the world uses these reusable covers so that they don't have to re-sterilize their camera and use that specific equipment. And so this is a military hospital in Vietnam, and we're using reusable trocars. We have a plastic cover over this, and we have the standard tower that you see. And this is a military hospital in Kyiv. Same thing. We have a cover over our camera so you don't have to re-sterilize it, reusable insufflation tubing, and reusable port. And so the reality is these pre-packaged sterile kits for easy deployment for laparoscopy, for NGOs, for MSF have already existed and are out there. So laparoscopic equipment can be portable, can be cheap, and it's much, much easier to send that far forward than a CT scan. For emergency general surgery, we know that this has a much quicker return to duty. And I want to look a little bit more about this, what's been alluded to already, the non-therapeutic exploratory laparotomy. So when we look at the civilian rate of incisional hernia after emergency trauma laparotomy, it's not zero, right? And if you look at it, if you have recurrent operations, either during the admission or post discharge, that rate goes up. And this is particularly relevant for our situation because, as I said, at every level, these are very dirty, infected wounds. We don't often have imaging. At some places, we're going to re-explore these patients, particularly if they just don't look right. We're going to be worried that something was missed. And so in the civilian literature, you have about 15.6 per thousand annual rate of incisional hernias for trauma. The military actually looked at this, and so our incisional hernia rate is higher. It's 19% for all of the trauma laparotomies that we did in combat surgery. And so you've seen these pictures. We've had people that are blown up. They've stepped on IEDs. They have multiple limb injuries, distracting injuries, head injuries. What is the non-therapeutic rates? This is very important, right? So if we're going to advocate for far-forward laparoscopy to reduce the level of non-therapeutic trauma laparotomy, we have to know what this rate is. And it's actually almost a third of the combat laparotomies that we have done. So I wanted to make sure that I'm glad I was able to be the end so I can talk about how important laparoscopy can be in this situation. Lightweight and portable. It's preferred for EGS cases. It can prevent non-therapeutic laparotomies, of which there is about a third incidence in our previous conflicts. It may be safer than non-operative selective management. Again, most of us may see that flank injury and do serial abdominal exams, but if you're in a dynamic theater where the chopper's leaving now, so you got to get your patients out to medevac, you're not going to have that chance to do serial abdominal exams. And so a diagnostic laparoscopy can let you medevac that patient with confidence. And then we also have debilitating long-term consequences if we have a lot of non-therapeutic laparotomies. So in summary, endoscopy and laparoscopy should be available at the Roll 2 for the next theater. Thank you.